I hope you have had a good break. We are going to continue on with some of the diagnostic tests that's available to assess the blood system. And we are going to start with the full blood count. Now, when it comes to the full blood count, with the advancement in technology today, full blood count is no longer done in a manual manner where you smear the blood onto a slide and start counting the type of blood cells that you see. These days, full blood count is being done using an automated counter where you just provide a sample of the patient's blood sample to the automated counter, and it will then churn out a strip with all the patient's details as well as a series of numbers that comprises of your blood counts as well as white blood cells differential counts, right? Your leukocytes differential counts. Now, what we'll only be focusing in this particular recorded lecture will be on the red blood cells in the index in red here. In particular, we will be looking at your red blood cell counts as well as your hemoglobin concentration. In fact, your hemoglobin concentration is the most important parameter here when we assess if somebody is anemic or not, because we know that the hemoglobin is that main component of your red blood cells that tie down oxygen and deliver oxygen to the tissues in need of oxygen supply. The red blood cells count may or may not be low depending on the type of anemia that we are seeing, but hemoglobin concentration is that number one number that we will look at. Other than red blood cells and hemoglobin concentration, we will also be looking at MCV, MCH, MCHC as well as hematocrit. These are all red blood cells index, and we'll go through them one by one. Alright? So, why are we looking at red blood cells indexes? Red blood cells index is in fact the number one number that sheds hints on the type of anemia or the cause of the anemia that we are seeing. One of the first one would be your hematocrit. Essentially, if we spin down the blood sample, we will have an overall volume of the red blood cells in the body. So this gives you the first indication on whether the volume of red blood cells is within the normal range that we are expecting to see. So in female, usually it's between 33 to 44%. For male, it's 41 to 50%. Again, you don't have to remember this range. It's usually given to you. Now, hematocrit gives you an overall view of the total volume of red blood cells. What we will usually also look at is actually the volume of each red blood cells itself. So in addition to the overall volume, we will also look at mean corpuscular volume. And what mean corpuscular volume reflects is essentially the volume of each red blood cells itself. In other words, the size of the red blood cells, right? So MCV is an indication of the size of the red blood cells. So when somebody comes in with an MCV that is within the range that is given, that's when the cells appear healthy and of normal size. We call it normocytic. If somebody comes in with red blood cells with a lower MCV or lower volume, that's when the size is lower than normal. We will coin it as microcytic. And on the contrary, if the red blood cells is bigger than usual, that's when it's coined as macrocytic. So all these differences in sizes would actually be of value when it comes to finding out what are the potential causes of the anemia that we are seeing. And that's what we are going to discuss in the next slide itself. Other than the volume of the red blood cells, we can also look at the amount of hemoglobin inside each red blood cells as well. In other words, the absolute weight of the hemoglobin per red blood cells, and that is reflected by your MCH, mean corpuscular hemoglobin. Now, MCH sometimes may not be of great value because what we are more interested in is actually the concentration of the hemoglobin inside the red blood cells, right? So instead of the absolute weight, what we can do is to also look at the concentration of hemoglobin, mean corpuscular hemoglobin concentration, MCHC, right? And this can be calculated by dividing MCH with your MCV, right? Your volume, your weight divided by your volume will give you the concentration of hemoglobin inside each red blood cells. And that's important because what happens is that your concentration of hemoglobin actually gives you an indication on how much hemoglobin you have inside the red blood cells. So if somebody has an MCHC that is within the normal range, we will call it as we'll call them normochromic, right? The red blood cells has normal color, normal chromicity, right? But if the concentration of hemoglobin inside the red blood cells is lower than normal, that's when the red blood cells appear lighter in color, and hence they are also known as hypochromic. There are also rare instances when the hemoglobin concentration can be more than the expected range. That's when we call the condition as hyperchromic. Right, and this is a rather rare condition which we will also discuss in our next slide as well. We don't tend to have red blood cells that are hyperchromic in nature, but only in very rare circumstances, which I'll share a little bit more in the next slide. Alright, so now that you have learned all the red blood cells index and what they actually means, we're going to look at how we actually make sense from this red blood cells index that we have discussed. Now, essentially, your red blood cells index are the ones that provides you with initial hints on the cause of anemia. So in order for us to know how to find out the cause in anemia, the first thing we need to know is what exactly is anemia, right? And when it comes to the exact definition of anemia by WHO, essentially it is a condition when your hemoglobin is lower than normal, and it may or may not come with lower than normal RBC count, your red blood cells count. But essentially, whenever somebody has total hemoglobin concentration that is lower than normal, that's when its oxygen capacity in the blood is compromised, and there will be compromise in the delivery of oxygen and hence anemia. Alright, so when somebody has anemia, we can actually look at the red blood cells index to find out further on what could potentially be the cause of the anemia. In this case, we can first look at the MCV, for example, or the size of the red blood cells. So when somebody comes in with anemia, but the cells or the RBC appears normocytic, normal in size, it looks healthy, there's little chance that it is because of the hemoglobin production being compromised. The cells are all filled with sufficient amount of hemoglobin, the size is normal, and it looks healthy. So if there's still anemia in such instances, then there's a good chance that the anemia is because of increase in the loss of RBC, for example, in situation of acute blood loss. Or it could be the other way around. There is something that's hampering the production of red blood cells itself. For instance, in renal disease cases where EPO production is affected, so then RBC production is hampered, and hence there is insufficient amount of RBC in the blood, despite normal looking RBC. Now, other than normocytic anemia, we can actually have instances when MCV is low, and that's when we have macrocytic anemia. The red blood cells appear small, and this is an indication that there's insufficient or abnormal production of hemoglobin. So what this means is that during the erythropoiesis of process, the red blood cells is not sufficiently filled with hemoglobin, and it can't achieve the size that that we expect it to be. Right? So what are the potential causes of microcytic anemia? It can be, for example, when there's iron deficiency. So when there's insufficient iron, you can't produce enough hemoglobin. That's when you can't fill up the red blood cells sufficiently, and the red blood cell appears smaller than usual. Or you can also potentially have microcytic anemia when there's hemoglobinopathies, right? Disorders related to the hemoglobin, right? So this is something that you'll learn in, again, Dr. Ben's lecture later on. For example, in thalassemia, when there's dysfunctional hemoglobin being produced, that's when microcytic anemia may happen. Now, other than microcytic anemia, the size of the anemia can be of the opposite direction as well. That means the MCV is high, and instead of seeing small RBC, you are seeing extremely large RBCs being produced. And some of you may think that, hey, isn't this good? We have bigger RBC, means we have bigger oxygen carrying capacity. Now, that's not necessarily the case, because big RBC means that it may not be able to pass through the tiny pores in the capillaries, and because of that, when it tries to squeeze through, it may burst, and that hemolysis or bursting of RBCs may then result in hemolytic anemia as well. Okay, so yes, when there's big RBCs, what could potentially cause this to happen? Now, one of the most common cause of macrocytic anemia is when there's impaired DNA synthesis, or something that hampers the division of the red blood cells during erythropoiesis itself, right? So how this works is that we know that during the division of the erythroblasts, the pro-erythroblasts, you will need a lot of DNA synthesis to occur in the cells, as you can recall from the erythropoiesis process. But if DNA synthesis is hampered, the cells will only grow in size, more and more organs, but it can't actually duplicate, it can't divide. So what this means is that there will be very large cells being produced, and it can't divide into a lot of red blood cells. As a result, very big red blood cells are being released into the circulation, and that is when microcytosis happens, microcytic anemia happens. Okay, and this can happen when you have vitamin B12 or folate deficiency, because we know that vitamin B12 and folate is required for DNA synthesis, and when this is hampered, that's when the cellular division is hampered and big red blood cells are being produced. Of course, there are also medications that may inhibit DNA synthesis as well. For example, in cancer patients, there are some cancer drugs that actually inhibit cellular division, and when this happens, macrocytic anemia may happen as well. Okay. Now, understand that this may be this may be information overload, but don't fret, because we will be revisiting this concept later on during the live discussion. So if you are confused or a bit confused now, don't worry. We will be relooking at this again later on to clarify things. Alright, so other than size of the red blood cells, we can actually look at the color of the red blood cells itself, and that can be indicated by your MCHC. So when MCHC is normal, that's when the color is normal, and we coin it as normochromic. So if your red blood cells has normal size and normal color, we know that hemoglobin concentration is normal inside the cells, and it is unlikely due to hemoglobin related issues. It's not hemoglobin production or synthesis issues, right? It's likely due to increased red blood cells loss or reduced red blood cells production. Similarly, if we see a drop in MCHC, that's when the color of the red blood cells appears more pale, or what we call hypochromic. That's an indication that there's insufficient hemoglobin in the cells. Okay, and when this happens, this is an indication that there's insufficient production of hemoglobin. Again, this is also tied to microcytic anemia sometimes, because in iron deficiency cases, for example, you'll see that microcytic anemias can be accompanied by hypochromic anemia as well. So you can have microcytic hypochromic anemia. The cells appear small and it's also paler than usual, lighter in color than usual. Other than hypochromic anemia, sometimes you can have hyperchromicity as well. This is rare, like what I've mentioned before. Your FCHC is higher than usual. That's an indication that there's too much hemoglobin in the cells. This is rare and only seen in spherocytes. Right? Spherocytes are essentially red blood cells that has lost its biconcave shape. Right? It doesn't appear in biconcave shape; it appears in a round shape because in certain congenital diseases, the red blood cells has mutation that of protein on the outer membrane that causes the red blood cells to lose its biconcave shape. It appears round in shape, and hence it can squeeze in more hemoglobin into the cells. So what this means is that it can have more concentrated amount of hemoglobin, but that's not necessarily a good thing, because the round hemoglobin may not be as elastic as the usual hemoglobin, so it may not be able to squeeze through the tight capillaries in the reticular endothelial system as well, so it may burst easily. Now, spherocytes that are round may not have the necessary hemoglobin to surface to volume ratio. And what this means is that the delivery of oxygen from spherocytes can actually be compromised as well. Okay, but again, like what I've said, this is a rare instances, and we won't be discussing much on this as well. Okay, now we are done with full blood count and also the red blood cells index. What we are going to look at next would be the reticulocyte count. Now, if you recall from the erythropoiesis slide that we have discussed previously, reticulocytes are your premature red blood cells that enters into the bloodstream right after the completion of erythropoiesis, right? And we said that it takes about 1 to 2 days for reticulocytes to mature, and there's only about 1% each time of reticulocyte in the circulation. So what this means is that we can actually look at the reticulocytes in the blood and see and look at the erythropoiesis process at any point in time. In other words, we can actually stain the reticulocytes, and then you can see from here that those premature red blood cells that has remnants of endoplasmic reticulum can actually be stained easily. And by counting the number of reticulocytes, we can actually have a good sense on the rate of erythropoiesis that is ongoing in the body. If somebody has a reticulocyte count that is lower than the expected range, we know that something is hampering the process of erythropoiesis, and we got to find out why. On the contrary, if let's say erythropoiesis is happening at a very high rate, you'll see the retic count being higher than the expected range, and that is something that we have to figure out why as well. Okay, so remember to attend the live discussion session later on, because that's when we will learn how to apply the retic count into figuring out what's happening when somebody has anemia. Okay. Alright, that is about it for reticulocyte count. The last diagnostic test that we are going to discuss about would be on your PBF, peripheral blood film. Okay, now peripheral blood film is a rather simple test that is being done in the lab. Essentially what is being done is to have a sample of your patient blood smeared to a slide, and it's being looked and scrutinized under the microscope. So if, for example, a good healthy red blood cells is being observed, then yes, you have normal red blood cells that appears under the microscope. But other than normal red blood cells, we can actually scrutinize for several other characteristics of red blood cells to know, or to find out some indications on what could be going wrong in the patient's blood. So for example, we can look at the size of the red blood cells itself. Of course, you can have microcytosis or macrocytosis, right? Difference in sizes. Sometimes we may see red blood cells of different sizes. It can be small, big, and normal all together, right? And that's when we coin it as anisocytosis. It's not just small or big itself. It's really a mixture of big and small. We can actually also look at the appearance of the red blood cells itself. Of course, we have learned hypochromic cells, red blood cells. So when there's insufficient red blood cell hemoglobin, that's when hyperchromicity can be seen. We can sometimes also see other type of red blood cells. For example, we can have target cells, right? The red blood cells appears as if it has a bull's eye, and there's a dark red mark in the center. Or we can also have protein aggregates in the center of the red blood cells. That's when we call that's what is called inclusion bodies. So target cells and inclusion bodies are signs of hemoglobinopathy. So when there's conditions or disorders related to dysfunctional or dysregulated hemoglobin production, that's when you may see target cells or inclusion bodies in the peripheral blood smear. Right, this will again be something that you will learn from Dr. Ben's lecture later on, or if not, you will be seeing this in your CLC as well. Okay. Now, other than the appearance, you may actually look at the different shapes of the red blood cells as well. So, for example, spirocytes is one of them. But of course, sometimes we can see RBC fragments as well. For instance, in cases of hemolytic anemia, right, the red blood cells are lyse, and you will see fragments of the red blood cells instead of normal red blood cells. Sometimes you might even see red blood cells of different shapes and sizes. That's when we call it poikilocytosis. You have all sorts of different shapes of red blood cells. Other than the shapes, we can also look at the maturity of the red blood cells through PBF itself. So that's something that we have discussed in our previous slide. We can actually look at the reticulocytes and count the number of reticulocytes in the slide itself. Now, other than reticulocytes, sometimes we may see very immature red blood cells. For example, we see erythroblasts inside the peripheral blood smear. Or in the case of macrocytic anemia, sometimes you might even see huge erythroblasts known as megaloblasts, right? And erythroblasts and megaloblasts are not something that you expect to see in your PBF because they are not expected to be inside the circulation itself. When this happens, there's good indication that the patient may be suffering from severe and chronic anemia. And when you see megaloblasts, that's an indication of macrocytic anemia. Sometimes we also call it as megaloblastic anemia, right? And this is something that we will again discuss further in our live discussion later on. So yes, that sums up the three main diagnostic tests that we will be learning for this recorded session. How we will be applying them to assess the blood system is what we are going to do in the live discussion later on. So please attend the live discussion so that we can reinforce on your learning from here onwards. Now, in summary, what we have learned from this recorded session, number one would be the process of erythropoiesis and how it is regulated through a negative feedback loop. Number two is that if this regulation is being disrupted, right, the production or the removal of red blood cells would be disrupted, and when this happens, either anemia or polycythemia will happen. And lastly, anemia can actually be evaluated either by looking at the quantity of the red blood cells or the quality of the red blood cell itself. I mean, when we use the word quality, what we are referring to is actually the size as well as the shape of the red blood cells itself. Okay? And how we actually apply this to assess anemia is what we are going to learn in the next live lecture. So yes, that marks the end of this recorded session. If you have any question, feel free to email me. If not, we can discuss this further in the live session subsequently. With that, thank you, and I hope to see you in the live session.